Bismillahirrahmanirrahim. Good morning, everybody. Sorry we are late. Maybe the audience will come more and more. It's my pleasure to share this session with Dr. Hala. And this session will talk about the main about trigeminal autonomic cephalalgia and other types of headaches. The speaker, Professor Ayman Nasif, Professor of Neurology at Shams University, and he will talk about trigeminal autonomic cephalalgia types and classification.
Bismillahirrahmanirrahim. Thank you, Chairperson, for your introduction, and welcome to our guest speaker in Egypt. Today we'll go rapidly to the classification and the main clinical picture for the trigeminal autonomic cephalalgia, and will not go through deeply in the management because the next speaker will discuss the management in detail. First, we'll go through the innervation of the cranial structures. The somatosensory innervation to the head is primarily the trigeminal nerve and the upper cervical spinal cord segments. The trigeminal innervation of the meninges and the meningovascular structures is via small unmyelinated C fibers to the caudal trigeminal nucleus, which extend to the upper cervical cord. Activation of the trigeminal vascular nerve is also accompanied by release of the neuropeptides, substance B, and calcitonin gene-related peptides. The second order pathway from the caudal trigeminal nerve is through via the choanothalamic tract primarily to the ventro-posteromedial nucleus of the thalamus. This is the classification of the trigeminal autonomic cephalalgia, which contain the cluster headache, paroxysmal hemicrania, short-lasting unilateral neuralgiform headache attacks, and hemicrania continua, and if the diagnostic criteria is not fully fulfilled, we can diagnose as probable trigeminal autonomic cephalalgia. The tests share the clinical features of the headache, which is usually lateralizing, and often prominent cranial parasympathetic autonomic features, which again lateralized and ipsilateral to the headache. These syndromes activate the normal human trigeminal parasympathetic reflex, which with clinical signs of cranial sympathetic dysfunction being secondary. Typical migraine aura can be seen rarely in association with tests. First, the cluster headache. The attacks is so severe, strictly unilateral, which is orbital, supraorbital, temporal, or in any combination of these sites, lasting from 15 to 180 minutes and occurring from once every other day to 8 times per day. The pain is associated with ipsilateral conjunctival injection, lacrimation, nasal congestion and rhinorrhea, forehead and facial sweating. This is the parasympathetic overactivation plus sympathetic dysfunction, which include ptosis, meiosis, and eyelid edema, and or restless and or agitation. The pain is so intense up to the patient usually trying to attempt suicide, and the pain so continuous with boring and burning in character. Characteristically, the attack awakens the patient from sleep. In contrast to the migraine, the patient in the cluster headache is anxious, moving around, and the attack tends to last for several weeks, after which the patient go into remission, which lasting from months to 1 and 2 years. The migraine ratio to cluster headache usually from 5 to 1, and is characteristically the cluster headache is relieved by oxygen. This is the diagnostic criteria. As mentioned before, we'll add only that the attacks, at least the patient must have at least 5 attacks to diagnose cluster headache, and the duration, as we said before, and either one of these following: parasympathetic dysfunction or parasympathetic overactivation and sympathetic dysfunction, plus sense of restlessness or agitation. So the patient has one of these attacks, or even if he has no this attack, either or both of the these following maybe have sense of restless or agitation. You can diagnose cluster headache with this restless and agitation plus this characteristic type of headache. The attacks occurring from 1, as we mentioned before, every other day up to 8 per day. The attack can be provoked by alcohol, histamine, nitroglycerin. The attack usually, the onset starts from 20 to 40 years. And as we mentioned before, the men is more affected 3 times than women. The acute attack involves activation in the region of the posterior hypothalamic gray matter, and the cluster headache in 5% may be autosomal dominant. Some patients have described both cluster headache and trigeminal neuralgia, and sometimes we refer to this syndrome as cluster tic syndrome. The attacks may be triggered by paint, perfume, petrol fume, and also by ingestion of alcohol. And the injection of alcohol typically induces the cluster headache within few minutes. And this is contrast to migraine attack, which can be also activated by alcohol, but within hours of ingestion of alcohol. The cluster headache is also again classified to either episodic cluster headache or chronic cluster headache. The episodic, the attack lasting from several days to 1 year, and remission occur at least 3 months. The patient must have 2 cluster periods, and the cluster period usually lasting from 2 weeks to 3 months. In contrast to chronic cluster headache, the attacks occurring for 1 year or longer without remission, or if the remission occurs, it will be less than 3 months. The management, I will not go in detail, but the management includes acute symptomatic treatment and prophylactic treatment with its transitional and maintenance. The acute symptomatic treatment include oxygen inhalation, somatotriptan, intranasal triptan, and dihydroergotamine. The transitional treatment includes steroid, greater occipital nerve block, intravenous dihydroergotamine, and lastly, the maintenance prophylactic treatment include verapamil, which is isoptin, lithium carbonate, and valproic acid, and lastly, topiramate. In 217, this paper indicates that naratriptan was taken before the patient went to bed has greater prophylactic efficacy in patients with cluster headache. This patient, in this, the result of this paper said that more than 80% of the patient, even naratriptan, before going to sleep by 2 hours, this gives greater efficacy for prevention of the cluster headache. So naratriptan has been suggested as a preventive medicine for cluster headache because the longer beneficial or biological half-life of this naratriptan in comparison to other triptan, so the internal use of naratriptan 2 hours before going to bed has good response in patients with cluster headache. Other preventive treatment, either peripheral neuromodulation as occipital nerve stimulation or sphenopalatine ganglia stimulation, or central neuromodulation as hypothalamic region deep brain stimulation. Paroxysmal hemicrania, usually the attack also so severe, strictly unilateral. The difference between paroxysmal hemicrania and the cluster headache is the duration. The duration only lasting from 2 to 30 minutes, occurring several times, and the same autonomic dysfunction, and typically they respond absolutely to indomethacin. This is diagnostic criteria. The patient must have 20 attacks to diagnose cluster headache, and specifically as absolute response to indomethacin. Also, it can be classified to episodic or chronic paroxysmal hemicrania, same as cluster headache, the episodic lasting from 7 days to 1 year, with remission period lasting at least 3 months, and the patient must have 2 bouts, and the chronic paroxysmal hemicrania, the pain is continuous for 1 year or more without remission, or if the remission occurs, it lasts less than 3 months. Patients with fulfilling criteria of chronic cluster headache sometimes have also association trigeminal neuralgia. And in this patient specifically, you must diagnose both syndrome because each syndrome needs a specific treatment. Sometimes to refer this syndrome as chronic paroxysmal hemicrania tic syndrome. And the recognition is important, as we said before, because the 2 syndromes need their specific treatment. The attack is so frequent, up to 40 times per day, And the key feature, as mentioned before, the good response to endomethacin up to 300 per day. Also topiramate and greater occipital nerve block has role in management. The third syndrome is the short-lasting unilateral neuralgia form headache attack, and the main differentiation between this syndrome and the other two syndromes is the duration of the pain. The duration of the pain only lasting from seconds to minutes, occurring at least once per day, and associated with the same autonomic dysfunction, but here usually the patient have lacrimation and redness of the ipsilateral. One per day, unilateral neuralgia form headache with conjunctival injection and tearing. In this syndrome, the patient must have both these signs, conjunctival injection and tearing, and the other syndrome, if the short-lasting unilateral neuralgia form headache associated with cranial autonomic symptom, any autonomic symptom like showering, washing or brushing the hair, shaving the nose, chewing, eating, talking, coughing, exercise, light, including sunlight or fluorescent light, may precipitate attack of SUNA or sunset. The pain in SUNA and sunset may be single steps, or may be each attack including groups of steps, or may be sawtooth in appearance or sawtooth pattern. Rapidly, the management will include intravenous lignocaine, will have good response to intravenous lignocaine, and greater occipital nerve block also with steroid and lignocaine have good response. The prevention treatment, the main treatment or the treatment of choice of SUNA and sunset is lamotrigine, topiramate, and gabapentin also has rule. The surgery affecting or aiming to affect the trigeminal ganglia, either compression or thermocoagulation or retroglycerin glycine glycerol rhizology or gamma knife surgery or microsurgical decompression, as we did in trigeminal neuralgia, occipital nerve stimulation, and also hypothalamic region deep brain stimulation. Last syndrome, which is hemicrania continua, the pain is persistent and characteristically respond absolutely to endomethacin, and is more classified to hemicrania continua, remitting type or unremitting type. The unremitting type, the pain continuous for 1 year without any remission, even 1 day. The remitting type, the pain is interrupted by remission period at least for 1 day. The differential diagnosis, if the patient has cluster headache, you must differentiate from migraine with prominent autonomic feature. The main differentiating point is the agitation which is appear in the cluster headache, and also the circadian and circumannual periodicity. If the patient has paroxysmal hemicrania, you must differentiate from cluster headache, and you may differentiate by good response to endomethacin. And SUNA on sunset, you must differentiate with the trigeminal neuralgia, and this differentiation by the autonomic feature and the agitation is common in SUNA on sunset, and the refractory period between the trigeminal neuralgia is not appear in SUNA on sunset. And also, this SUNA on sunset must be differentiated from cluster headache and paroxysmal hemicrania, and we can differentiate by the characteristic cutaneous triggering, which is common in SUNA on sunset, also the characteristic attack, which is stab or group of stabs or sawtooth appearance. The hemicrania continua, you must differentiate between cluster headache with background pain and from migraine with chronic background, and you can easily differentiate by absolute response to endomethacin. The pathophysiology rapidly for this syndrome is including 3 main manifestation, which is the trigeminal distribution of the pain, ipsilateral autonomic dysfunction, and the circadian and circumannual periodicity, which indicate that the hypothalamic is affected, and the stimulation of the trigeminal afferent can result in cranial autonomic outflow. The trigeminal autonomic reflex, in fact, some degree of cranial autonomic symptomatology is normal in physiological response to pain, but the patient with other headache syndrome often report this syndrome. The distinction between TAS and the other headache syndrome is the degree of the cranial autonomic activation, not its presence. The hypothalamic activation occur in SUNA and the cluster headache and in all TAS, and importantly, the involvement of the posterior hypothalamus may account for the rhythmicity or periodicity of the attack, and the direct hypothalamic trigeminal connection which has anti-nociceptive and autonomic response. Lastly, either this hypothalamic activation, it is pathognomonic, or either it's mere epiphenomena to the different pain syndrome. Till now, it is not resolved. This last slides, the 6 is more in the cluster headache, same 6 distribution in paroxysmal hemicrania. The severity of the headache is excruciating, and the remaining slides we already mentioned. Thank you.
Thanks, Professor Ayman. We can take one question. Okay, we shift to.
It's my pleasure to invite Professor Dr. Queen. He will continue talking about treatment guidelines for cluster headache. Please.
Thank you very much for the introduction. It's a pleasure to be here. I'm presenting on behalf of the European Headache Federation on treatment guidelines for cluster headache. I'm a neurologist working in Belgium. And, as we've heard, the trigeminal autonomic cephalalgias can be subdivided into cluster headache, paroxysmal hemicrania, Sunct Suna, and hemicrania continua. And there's little time to discuss all the treatments, so I will focus on cluster headache. But as you've heard before, paroxysmal hemicrania and hemicrania continua are really absolutely responsive to indomethacin, so that's really the mainstay of treatment. Whereas for Sunct Suna, the first-line treatment is lamotrigine. But for cluster headache, we've elegantly heard the criteria. I want to stress once more that in the new criteria, remissions in cluster headache have to be more than 3 months in order to qualify as episodic cluster headache. And as you can see here, there's often striking autonomic features ipsilateral to the pain. Patients try to express the severity of cluster headache attacks, as you can see here in this tattoo, or this lady who came into my office after being in an ambulance during an attack, banging her head. So this is something that you read in literature, but it's really happening, and it's showing how severe the pain is. Hence the nickname suicide headache. Patients with cluster headache live in fear for the next attack, uncertainty. They may have suicidal ideations, and there's been a few cases of suicide reported also recently. It's underdiagnosed, unfortunately, undertreated. And so really the focus of my presentation is on first-line treatments, because we know that many patients don't get the first-line treatments, including oxygen, sumatriptan injections, and verapamil. And many patients undergo unnecessary procedures. In my practice, 20% of patients have had a dental procedure, dental extraction, denervation, and so on. They go to several colleagues. And so it has a high burden on the patient. Treatment options, as mentioned, non-pharmacological medical treatments, and then intervention and neuromodulation treatment options will not be discussed here because the focus is on the first-line treatment. So non-pharmacological management should be to tell patients to eliminate naps and avoid major changes in sleep habits, because a cluster headache may be triggered during sleep. And they should, during their cluster periods, avoid alcohol. Some people are sensitive to volatile substances or solvents, and they should avoid certain drugs, such as sildenafil and nitroglycerin-based drugs. We also advise patients to quit smoking. Quitting smoking is not helpful for cluster headache. It doesn't reduce the attacks, but if the patient develops, for example, coronary artery disease, this will really be a problem for management, because triptans are contraindicated. We should also monitor patients for overuse, medication overuse headache, and we should advise against hallucinogens. There's a lot of buzz on the internet on LSD, magic mushrooms, and so on, so we advise against that. This is the abortive therapies, and the number 1 and 2 here are 100% oxygen, which should be administered for at least 15 minutes at a flow of at least 12 liters per minute. And also sumatriptan 6 milligram subcutaneous injections should be made available to patients on a twice daily basis. We have other options, second-line options. The intranasal triptans have some evidence from controlled trials, sumatriptan and zolmitriptan. Intranasal lidocaine, I must admit, has not been very effective in my hands. It's only an adjunct to treatment. And there are some other options. There's a proof of concept study with subcutaneous octreotide, but we don't really use it. Ergotamine and dihydroergotamine belong more to history now that we have the triptans. Here are some data to compare the different acute treatments. And as you can see, oxygen and sumatriptan injections, you know, they abort attacks within 15 minutes in around 75 to 80% of patients, which is better than the nasal sprays, as you can see here. And there's something else was 30 minutes for the nasal triptans. Whereas for oxygen and sumatriptan, it's 15 minutes. And that's why we really prefer those drugs, because the others are rather slow and attacks are very severe, so we need a fast onset of action. There's been a debate whether medication overuse headache exists in cluster headache, but there's been many reports with sumatriptan injection overuse that there may be an increase in cluster headache frequency, which is hard to detect. And also people overusing all sorts of drugs, opioids and other drugs, may develop a background headache on top of their cluster headache attacks. And this is mainly seen in patients with a history of migraine, so we have to look out for that. But I must admit that many patients would prefer a background headache rather than a withdrawal if you don't have an alternative to offer to them. Oxygen, you know, there's data that oxygen is underused. There are obstacles obtaining oxygen, and I would be interested in hearing how it is in Egypt and the rest of Africa. It's not reimbursed worldwide, and it limits mobility in patients. And this is something I really need to stress. We need to use this sort of non-rebreathing mask with valves and a balloon to have high flow oxygen. And the problem with oxygen also is that there's often an initial response, but a rebound that occurs quite quickly, so attack seems to be fragmented. As for transitional treatments, you can give a short course of oral steroids, but now that we have greater occipital nerve injections, that's become more of the first-line transitional treatment, because it's very easy to do at the back of the head. And a single injection will, in more than 80% of cluster headache patients, suppress the attacks for at least 4 weeks. So that's a short-term prevention that will be helpful in the management. And as mentioned, IV dihydroergotamine is available in some centers. The shortest course of steroids that has been reported to cause avascular necrosis is 30 days. That's why we use a 20-day course. There are several regimens around. But again, and this is mentioned in the migraine patients, even short-term intermittent pulses of steroids may induce osteonecrosis, even shorter than the 30 days. So that's why we limit steroids to 2 to 3 times a year. A Cushing syndrome with long-term use of steroids is well known, but it has also been reported with occipital nerve blocks, so that's why we limit those blocks to 4 times a year, every 3 months. Not really based on a large number of data. For example, for topiramate, there is no controlled data, but it's still considered by many second-line treatment. Melatonin and lithium should be limited to chronic cluster headache. The general rule is that you need to use high doses, higher than what you're used, for example, in migraine, with topiramate up to 400 milligrams a day, melatonin up to 15 milligrams a day, and lithium according to the plasma levels. There's a number of third-line options: gabapentin, sodium valproate, bezotifen, levetiracetam, really a few cases reported, and as been mentioned before, a long-acting triptan such as naratriptan before bedtime has been used to prevent nocturnal attacks. In the past, that used to be ergotamine. Now, here are the data for verapamil. This is a trial with 360 milligrams of verapamil a day versus placebo, 30 patients, small trial, and at week 2 we can see a significant reduction. This is the data that we are looking at for cluster headache prevention. Whereas in reality, we use this sort of scheme where you can go up to 960 milligrams a day. It is born out of practice. And I want to stress the need for EKG monitoring using these high doses. For example, this case where you can see that there is a PR interval prolongation over 200 milliseconds on 560 milligrams a day. If you reduce the dose down to 320, you get a normalization of the PR interval. The problem is that patients don't feel this PR prolongation, and if you keep increasing the dose, you may run into serious problems. For example, this case is a 19-year-old patient that walked into my office on 960 milligrams of verapamil a day, and he never had a cluster headache attack. And if you look very closely, I mean, he's bradycardic, but there's also no P waves. This is a junctional escape rhythm. So this patient went from my office to the cardiac care unit. So we really need to do those EKG monitoring. Verapamil may have some other side effects, such as lethargy, constipation. Patients should see a dentist twice a year for gingival hyperplasia. There can be some ankle swelling, and some other side effects may be nausea, hypotension, and a rare case of hyperprolactinemia. As for lithium, we have a negative RCT in episodic cluster headache, and we've seen already that there's been a comparison with lithium. Side effect profile of lithium is, problematic sometimes. So with tremor, nephrogenic diabetes insipidus, watch out for hypothyroidism, and that's why we really need to monitor several things, including the serum lithium levels, thyroid and renal function. And you also have to remember there's a number of interactions to look for with carbamazepine, NSAIDs, diuretics, which may alter the plasma levels of lithium. So my conclusion here is that cluster headache really is underdiagnosed and undertreated, and we should really focus on making available to patients first-line treatments. And those first-line treatments, recently there's been this publication which you may want to look at by the American Headache Society. They've done a review of all the treatments for cluster headache, and they gave them levels of recommendation. And as you can see, according to the AHS, sumatriptan injections, zolmitriptan nasal spray, because of 2 trials, and oxygen all receive a level A recommendation. So remember to use oxygen at a high flow, and of those subcutaneous sumatriptan. If someone has 7 to 8 injections a day, and I mean this is happening, I've just recently saw someone, then you have to think of withdrawing the patient because they may have an increase in cluster headache frequency due to the treatment. And zolmitriptan nasal spray really is not that effective, it's slower, but it also received the level A recommendation. As for the transitional treatments, personally we use occipital nerve blocks very often. If you haven't done them before, it's very easy to learn. It's something that you can do in the office, and it's very helpful. Around 4 out of 5 patients will have a benefit within a week that lasts up to 4 weeks. So that's really a bridge to long-term treatment. And we limit the use of occipital nerve blocks to 4 times a year, once every 3 months. As for prevention, the American Headache Society, every sort of prevention that we have only receives a level C recommendation. So we need to do better. Verapamil is really the first-line treatment for episodic and chronic cluster headache. But we have very limited data from randomized controlled clinical trials. And the message here is, even though we have very limited data, if you do use these drugs, you should use them and think of using high doses. Also with verapamil, but think of EKG monitoring. So there really is a need for new, effective, and well-tolerated treatments. And as you know, there's an emerging treatment with CGRP, pathway antibodies, and in cluster headache, the first results have been out there with galcanezumab. In episodic cluster headache, there was a positive trial. In chronic cluster headache, the data were negative, so that's something that will be well tolerated. And of course, there's a number of neuromodulation treatment options, vagus nerve stimulations, phenopalatine ganglion stimulation, occipital nerve stimulation, and in very refractory cases and specialist centers, hypothalamic deep brain stimulation is still in use. So this concludes my presentation. Thank you very much. If there's any questions, I'm happy to answer.
Thanks, Professor Queen, for your clear, concise talk. Any question? Okay.
Okay, that's a very practical question. How do you decide when to stop a treatment in episodic cluster headache? So a typical patient will have a cluster bout between 2 to 3 months. So as a general rule, I would say you look at historical data. Someone who has had cluster headache for 10 years, and he will tell you it's always in autumn, and it always lasts around 6 weeks. With the next bout, you take this into account. Even though it's not exact science, you will look at the historical data. And a second bit is that, as a general recommendation, patients will start to taper down the drug after 2 to 3 weeks without any cluster headache attacks, or without any so-called shadow attacks. Because as you know, many people on treatment, when they are treated well, they will still have a sense when the attack is going to come on, but it's not. And this is called shadow attacks by patients. As long as they have a shadow attacks, I would not recommend tapering down the drug. So it means at least 2 to 3 weeks without attacks and shadow attacks. But also, again, if someone has had a very prolonged bout of, for example, 7 months, I would rather go a bit slower than after 2 to 3 weeks. And that's a bit of a clinical judgment. Yes.
Any further question? Yes?
Thank you very much for a lovely presentation. Now, question of miserable acute cluster attacks where some patients think of suicides. And they have it infrequent enough, but severe enough. Maybe twice a year, seasonal or whatever, or you treated one very successfully. Would you consider doing prevention? Would you consider doing botulinum toxin for 3 to 5 sessions for such a case?
Mm-hmm. So the first thing I think is rather easy to answer. I would not use botulinum toxin for cluster headache, but as you may know, there is emerging data on the use of botulinum toxin at the level of the sphenopalatine ganglion, but that's still in research. I would say if there was a trial running, it's the sort of patient that you want to help and use additional treatments. Other than that, the question is, in a patient with severe bouts, would you continue the prophylactic treatment throughout the year? Personally, I don't. Because if someone has, for example, bouts that last 2 months, there's really no data to show that you can prevent the next bout by keeping them on the treatment. So what my personal approach is we have a next day sort of service for cluster headache patients, because the problem is that many patients they are on waiting list, have to wait, and they sit for weeks in a cluster headache. So we have, as a general rule, if cluster patients call, they will be seen the next day. We will do the occipital nerve block immediately, and we will start long-term prevention. And if in cases that are very severe, and as you say, maybe suicidal, we will admit for IV dihydroergotamine, because we have that available, but it's not available everywhere.
Many thanks, Professor.
Then the question then is about occipital nerve and other stimulators. The problem is reimbursement. For example, in Belgium, it's 20,000 euros for ONS. I think it's very different in different countries, so we really can't. Personally, I think for neuromodulation options at this stage, we have the best data for sphenopalatine ganglion stimulation, which is tested for acute treatment, but there's been an observation of a preventative treatment, and if it would be reimbursed, that for the moment would be my first choice.
Many thanks, Professor Queen.
Thanks.
Now is the time for the third speaker, Professor Tidisa Sedda. He's here? He's not here? You are here? Professor Tidisa is a consultant neurologist at Adama Hospital Medical College. His main work experience in Gemma University Specialized Teaching Referral Hospital in Ethiopia. He will talk about neuromodulation impact on chronic migraine management.
First of all, I would like to thank the organizers in inviting me to attend this very important conference. And as you can see, this is a station office for African Union, which brings different African countries together in Ethiopia. So my topic of presentation is neuromodulation impact on management of chronic migraine. So this is to show the gap between medications and the possibility of neuromodulation in science. So I will have introductions and types of neuromodulations, indications, and different contraindications. So we have done conducted a research in Adama Hospital on 248 patients with complaint of headache. We found that a very significant type of patients had migraine headache, about 42 cases, which is 70%, which is very significant. So this is to show the age and gender difference of migraine. So as you can see, the most productive and reproductive age group are affected, and the females are mainly affected, so it has an impact on economy, productivity, and the quality of life. And this again shows how migraine without aura and with aura. The most common is without aura and affecting also females and young age groups. And the area of the brain focused on neuromodulation is perireceptor area in the cingulate gyrus, and also in the midbrain, raphe nucleus, and different preaqueductal and the somatosensory cortex are very important areas to focus on neuromodulation. So if we change these dysfunctions, we can control migraine headaches. And the most important structure again is the thalamus, which is a sensory input to every part of the brain. Every sensory input passes through the thalamus. It is selected, and different sensory symptoms can be filtered. So if it is affected, so the different area of the thalamus can induce different sensations. So sensory modalities can be changed. And the different neuromodulations are just for treatment of chronic headache, interactable headache, and with this plastic change in the brain, also augments the different pharmacological therapy, and also to maximize the long-term treatment. And also it's important for aborting acute treatments. So the different neuromodulations are the transcranial direct current stimulation, and the transcranial magnetic stimulation, deep brain stimulation, and vagus stimulations are non-invasive type of neuromodulations. So as you can see, the transcranial direct current stimulation applied the direct current to the scalp, and then there are different electrodes which can build the electrical discharge, abnormal electrical discharge. So there is a controlling segment of different electrodes. So it can be continuous or variable electrical stimulus, so that can avert the different abnormalities of electrical discharges. The other one is transcranial magnetic. This is a magnetic plus electrical stimulation. A magnetic surrounds the brain. So a strong rapid current will pass through the coils, so that stimulating the cortex. So there are stimulating the different proteins are activated, and also alteration of genes and also receptors are changed. So the different neurons are also stimulated and de-stimulated. The transmagnetic stimulation is usually used to treat severe migraine and improve cognition, attention, and memory, and also in treatment of mood, motion, emotion, behavioral, and also depression. So it has dual therapy, so both neurologic and psychiatric importance. So there was a research conducted the effect of transmagnetic stimulations. So before and after transmagnetic stimulations, the frequency of migraine is significantly decreased, and also there was a study conducted to show the glutamate or different neurotransmitters involved during migraine. So by transmagnetic stimulations, the different neurotransmitters are also decreased. This means there are involvement of different neurotransmitters in migraine. So monitoring mechanism is either online or offline. That means online, different imagings can be showing the function and dysfunctions of the brain, metabolic activity of the brain, and offline is long-term therapy. After using magnetic stimulations, what is the recurrence of migraine or pain stimulation? Is it recurrence or long-term ablation? The other way of monitoring is spectroscopy. Measuring the different metabolic activity in the brain, like oxygen consumption, glucose consumption can be measured. The effect of magnetic stimulation can be measured. The other is using EEG, electroencephalography, control EEG before stimulation and after stimulation, so that we can measure the effect of magnetic stimulation in the brain. The problem is it is usually applied in the cortex and cerebellum, but doesn't reach the deep brain. That is the most efficacy. And the other is the frequent visit to hospital. Patient with stimulation needs frequent hospital, and there is a risk of bleeding, infection, and also it is cost and availability is a question. The other is deep brain stimulation. This is the targeting area of the brain, like basal ganglia, thalamus, and also the brain stem. So there is a different coils, ring, electrodes inserted in the deep brain, and there is a pacemaker attached to the chest or the abdomen, which controls the different impulses of electrical discharge to the deep brain, so that can be monitored. So usually this one is used in case of movement disorders like Parkinson's disease and epilepsy and also migraine. The problem with this is still these patients need frequent visiting of hospital, and the risk of bleeding and infection is the cost, and it's available is also a question. The last one is vagus nerve stimulation. This again, there is a pulse generator attached to the chest or the abdomen, and there is a ring, electrode ring, thin fibers inserted to the area of the vagus, and there is a controlling machine which controls the different impulse, electrical impulse applying to the vagus. So it is usually used in treatment of epilepsy, trigeminal neuralgia, and migraine headache. So in my presentation, what is the take-off message is, so there is a gap between managing chronic migraine pharmacologically, so that there is a science and advantage of using this technology if it is available. So chronic management of migraine needs attention in case of irresponsive treatment to the standard medications. And also focusing on the neural technology is very important for both neuroscience and also for the benefit of the patient. And it needs also further research on its application. So these are the gaps I want to show in the future things should be done in management of chronic headache, especially chronic migraine, in response of which are not responding to the standard medications. So these are, if you have a stable family, no more headache. So thank you very much.
Thanks, Professor Tidisa. And we can take one question. Okay.
Thank you. My question is related to TMS. I would like to know if it is really useful in daily activities, in daily practice, and if yes, regarding monitoring, which activities on AG on AG do we have to focus on?
Yeah. You see, EEG, normally we use electroencephalography in diagnosing of different psychiatric disorders and epilepsy. But in this case, normally the neural functions, the normal functions of neurons are known. And in epilepsy is also known what pattern of epilepsy pattern, or electrical discharge of neurons in the brain, in the cortex. But in this case, after migraine, there also change of neurons, activity of neurons, because of different neurotransmitters are affected, metabolic of the brain is affected, and also diffusion, cerebral perfusion is, and oxygen consumption also changed. That pattern is different from EEG, the normal the patterns of EEG in epilepsy. So the metabolic changes are there, the cortical activity is also, so it has got its own electrical activity which is different from the other pathology of EEG recurrence in epilepsy. So you can show, it can show which part of the brain is during a migraine attack, which cortex have an abnormal electrical discharge on EEG. So this is one. The second one is control EEG. This is control. When there is no migraine, there is no abnormal EEG. So during the migraine, you can find abnormal electrical discharge at that occasion, in that duration, so that the record can be adjusted so that you can follow whether the efficacy of this magnetic stimulation is.
English is a bit difficult for me. Do I understand that we have to record during migraine fit or early after the fit?
Yeah, so you can record before migraine, like aura, and during migraine, and also without aura, so that it can give you a clue, and that is how to follow whether this stimulation is effective. So when you apply magnetic stimulation, so you are already de-stimulating the neurons, or the excitatory neurons are activated or deactivated. The inhibitory neurons are also, depending on the severity and the occurrence, the focus of the brain. So I've tried to show you which brain areas are very, very important in migraine generating. So these are the focus. So you can look at whether this normalization after stimulation or not.
Okay, thanks, Professor Sidda. Next speaker.
Dr. Yasser Malik, Rashid Hospital, Dubai. He's neurologist. Will talk about effect of headache on memory.
Bismillahirrahmanirrahim. Thank you, Chairperson. Thank you, the organizing committee, for inviting me here. I feel, in fact, privileged to speak on this forum. I'll be talking about the memory. Is it affected by the headache or not? So this is the place where I work. I would distribute my talk into the three main segments. First of all would be whether the primary headaches are directly affecting the memory or not. The second one is the comorbids, their role on the memory. And third one is the treatment, how it is affecting the headache. So let's talk about migraine first of all. Due to the high lifetime prevalence of migraine in the general population and an increasing life expectancy, a causal association between the migraine and the cognition is more likely, cognition impairment is likely. This is based on the vascular theory of the migraine. that initially there is vasoconstriction, then there is vasodilatation, and it was hypothesized before that might be this is a mechanism how the headache migraine people are having more prevalent strokes, and maybe there is the same mechanism actually. First of all, there is a trial, it was a cross-sectional studies that looked at cognitive performance. In just amongst the migraineurs, they used the Ray complex figure test, and this was correlated, the abnormalities in this test were correlated by the, according to the location of the migraine. And they found that amongst the migraineurs with the ARA, these are, there is more worse recall if this migraine is located in the right side or it's bilateral. Whereas amongst the patients who are having non-migraine, ARA without migraine, migraine without ARA, the recall is more delayed if it is bilaterally located. So in the same way, there is another Italian-based survey. They took 72 consecutive patients of migraine without ARA and the 72 healthy subjects. They did MOCA tests, back refresh inventory, 2 self-version of apathy evaluation scale, and state and trial anxiety inventory, and they found that there is subtle cognitive dysfunction and low percentage of behavioral symptoms that is found in the migraine years. This is the description of the same studies table. As you can see, they compared the patients migraine with ARA and the healthy subjects. The total MOCA was reduced significantly amongst the patient with the migraine with ARA. And moreover, if you go into the detail, the 5 subtypes of the cognitive function, you find the executive function and the memory that is impaired in the patient. 536 was normal, so nothing was reported there. So according to them, there is the migraine year twins, they did not have any difference in the memory and cognitive subtypes. So the previous studies which I mentioned, these were mainly cross-sectional studies. Let's talk about the longitudinal studies. 4 in this context are very important. Number 1, the ECA from the USA. Number 2, the MAS from the Netherlands, EVA study from the France, and WHS. They compared migraineurs and non-migraineurs, and there was a good number of the patients there, and the controls, they were having equal cognitive and psychological assessment. There was no memory impairment. So what was the reason here? It was a longitudinal study, and they could not find anything. One of the points which I need to mention here that is important, they followed the cognitive and neuropsychological assessment. They did only once or twice in whole this period. So one of the study did in once, one of the study did twice or thrice, or like that. So probably if they would have followed it for the longer period, or maybe for the more frequent, the results would be different. Let's talk about the cognition in the children. The prevalence of migraine is said to be 2 to 17%, and that of tension type headache is 0.9 to 24%. Mainly, they did not, as a whole, in the intellectual quotient, they did not find any difference between the patients with migraine and the controls. Let me tell you this, in this table, they distributed different forms of the intelligence amongst the patients with migraine with ARA, tension type headache, and compared that with the controls. In this context, few things were very important. That the verbal intelligence quotient and the verbal intelligence quotient in relation with the performance intelligence quotient, that was significantly reduced in the tension type headache, whereas the performance perceptual organization was significantly reduced in the migraine patients. So there are a few things in the children age group that is also affected by the migraine and the tension type headache. There is a systemic review that took 2 types of studies, like some of them are clinic based. Patients are coming to neurology clinic and interviewed there. And some of them are the community based. The doctor would go to the community and survey all the patient like to assess the prevalence. So they took 23 studies, and 15 out of this found that there are some abnormalities in neuropsychological assessment. Surprisingly, all the studies, or majority of the studies who were having these abnormalities, they were clinic-based studies. And majority of the community-based studies, they were showing that these neuropsychological assessment is majorly normal. So what is the reason here? Mainly what I believe after reviewing all these things, that number 1, the clinic, you have sufficient time to do all the batteries, neuropsychological assessment and everything, and the community probably you don't have such time to do it in detail. Number two, when you're going to the community, you're taking the patient as a whole patient, not a neurology patient. So whatever you will ask him, whatever is more important for him, he would tell you that. Like maybe arthritis or maybe the acid peptic disease is more important for him rather than migraine or rather than the memory impairment. So maybe that was the reason why the community-based studies did not show any memory or neuropsychological impairment. Anyway, whatever was reduced there, mainly it was visual and verbal memory, reduced information processing, speed and executive functions, and attention deficit amongst the patients. Let's talk about some of the radiological studies. This is a study based on functional MRI. They took 14 cases and 14 controls. And what they did is that during a normal period, when the migraine patients are not having migraine and controls are also normal, they gave a painful stimulus that might be a thermal painful stimulus or so. And in the meanwhile, they gave them a cognitive task, and in the same time, they did the functional MRI. And they found that amongst the migrainiers, there was delayed deactivation within the left dorsolateral prefrontal cortex and left dorsal anterior mid-cingulate cortex. I would be showing this in the next slide. So here, different areas which are mainly involved in the migraine, these are enhanced here. Many of them are focuses mainly in the left dorsolateral prefrontal cortex and the anterior mid-cingulate cortex. You say these are enhanced during the migraine. These are, in fact, involved during the migraine. So this graph is showing this purple color is for the migraine patients and the gray color is for the controls. If you see here, during the pain stimulus, the deactivation is reduced in the migrainiers. If it is down, it means it is less. So if it is up, it means it's more. So it is reduced, the deactivation is reduced amongst the migrainiers in all these three stimulations. The dorsolateral prefrontal cortex, anterior mid-cingulate cortex, and the right cerebellum. So that showed that somehow the migraine is associated with the memory deterioration. They said one thing more, that these regions have been reported to have decreased cortical thickness and cognitive-related deactivation within other pain populations and are also associated with the pain regulation, suggesting that the current findings may reflect altered cognitive functions and regulation in the pain. So in the same study, there is another picture that is showing the superior frontal gyrus and the posterior cingulate cortex. These are involved in the migraine also, and these are showing, compared to the case and control, they are showing that there is reduced deactivation in the patients as compared to the controls. From radiological point of view, let's go towards another study, cerebral blood flow. They took 60 migrainiers and 30 controls in Spain, and they performed a SPECT scan, and they found that there was hypoperfusion in 43% of the patients. While on cognitive assessment, there was memory, attention, and visual motor speed was delayed. It was adversely affected. Few more studies about the SPECT scan. They are performed on the migrainiers and non-migrainiers and showed the significant hypoperfusion. There's a study that is conducted on the white matter lesions in the migrainiers. They compared the patients who have no history of headache, the patients who had migraine, and these patients who are having migraine but not the, who are having headache but not the migraine, non-migrainous headache. They did the white matter lesion assessment and then the MMSE assessment, and all the p-values were insignificant. They did not find any correlation between the white matter lesions and the memory. Similarly, there are a few more studies. They excluded the comorbidity for the white matter, and they found that the migrainiers are 4 times more likely to have white matter lesions rather than the general population. And later it was established in other studies that they are somehow correlated with the cognitive adversity, cognitive decline as well. The last study about the radiology, there is a study, they checked the gray matter density in the migrainiers versus controls based on MRI and the voxel-based morphometry, and they found that there is significant gray matter density reduced in migraine, and on cognitive assessment, these patients were having slower response to the time to take test shifting. Let's talk about the tension type headache. Few studies, they have mentioned that the patients, they compared the patients of tension type headache with the controls, and they found that 3 of the tasks like logical reasoning, retrieval from semantic, maybe 2 more minutes. Reaction time and categorical search, they were delayed. And another similar study that showed that global increase in the negative effect is common in the tension type headaches. Let's see about the comorbid conditions. General anxiety, sleep disorders, depression are correlated with migraine, and they have adverse effects on the cognitive things. So there is neurotransmitter theory that how migraine is generated. There are few neurotransmitters that are abnormally secreted, like dopamine and serotonin, and they can dopamine acts by the nociception or regulating the blood flow mechanism, either of them, and then that can affect the migraine. Serotonin also then can cause vasodilatation in the migraine, and there is muscle contraction in the tension type headache. And so this is a mechanism mainly from neurotransmitter point of view, how it is caused migraine and the tension type headache. So if these are serotonin, dopamine, and norepinephrine, these are being relieved in the very harmonized fashion, these things would be very good. There is very motivational. Can I give 2 minutes more? Just few slides. There will be good play, be good. That may lead to the mood disturbances and the cognitive impairment. So again, few studies said the psychiatric, these disorders like depression, anxiety, sleep disorders, these are associated with the migraine, poor cognition. So let's see the effect of the treatment on the migraine. There is a case control study on the migrainiers who are taking topiramate. They assessed the comprehensive neuropsychological and behavior assessment on the patients taking topiramate. They compared the patients who are not taking topiramate and who are taking the topiramate at baseline after the 8 weeks of institution, the therapy, and then after 8 weeks follow-up, and they found that there is word fluency score is reduced on both, and p-values was significant here. There was no psychological manifestation there. There's another 3 large multi-center advised double-blind placebo-controlled trials showing that 24.9% of the patients discontinued Topamex because of the side effects, and one of the main side effects was cognitive impairment. Let's talk about the amitriptyline, the emotional memory and the and migraine. Amitriptyline negatively affects emotional memory, especially the untreated migrainiers compared to the treated recall the most emotional phase of the memory or the story, arousal story. So they compared the patients of migraine who were taking amitriptyline with the patients who are not taking amitriptyline with the control. So there were 3 groups, and finally they evaluated the patients and the migraine was reduced. The cognitive impairment was definitely found there from the emotional point of view in the migrainiers. My conclusion was almost the same, that there is definitely, just last slide. So despite a relatively small number of studies and the methodological heterogeneity amongst investigations, it seems that migraine affects the cognition negatively. Migraine with ARA is more likely to cause cognition impairment as compared to the migraine without ARA. And some of the studies have shown that the frequency of the migraine and the long duration of the migraine has direct proportionate with the cognitive deafness. So that's all.
Thanks, Professor Yasser. I think we can postpone the question to the coffee break for sake of time. Next speaker.
Any question for Dr. Yasser? One question. Okay, we'll move now to the next speaker. Professor Hatim Samir is Professor of Neurology, Cairo University. He will talk about Cairo University headache clinic experience.
Bismillah ar-Rahman ar-Rahim. In my coming few minutes, I will try to present our work, what we are doing in Cairo University and what we are aiming at. This is my disclosure, and this is the site where I worked. Well, to start with, most of headaches are not life-threatening disorders, yet they are one of the most common neurologic disorders, and they have substantial disability impact on the quality of life of patients. With 1 year prevalence of migraine of reach up to 17%, and 90% of migraineurs have moderate to severe pain, 75% with functional disability, and 30% may require bed rest during the attack. The global burden of disease recognize that migraine and tension-type headache are the second and third most common disease globally behind dental caries, with high prevalence and prominent temporary disability. Its mistreatment and mismanagement lead to MOH, medication overuse headache, with more comorbidities associated with it and more disabilities. However, throughout the world, headache has been underestimated in scope and scale. Headache disorders remain under-recognized and under-treated everywhere, especially in developing countries. Here in Egypt, many barriers affect the patient's care. The first is availability of epidemiological data. Second is absence of specialized headache centers. Underestimation by the household members and also by general practitioner, insufficient patient education, and availability of pain relievers as OTC. But the most important is number of researchers and research facilities. Though in my institute there is about 100 neurologists, yet we are involved in many jobs inside the university, in addition to our private working, which keep much lower time for research, and also we have some obstacles in our research facilities. In a trial to bridge such gap, we established Qasr al-Aini headache disorder unit in 2013, which were founded by Dr. Tamawi and Dr. Sharif Hamdi, with our mission to provide expert advice for patients with primary headache disorders referred to us, and our vision to improve quality of life of Egyptian patients suffering from primary headaches by addressing different types of headache disorders. We started by referral sheet. And why is referral? First, to perform a registry for comprehensive assessment with whether laboratory or radiology, and for those patients who is resistant to treat. And this is a referral sheet from other general neurologists and from other specialties. The hierarchy of the clinic is the chair, with who is the head of the department, the directors, who is responsible for the plans, the moderator and consultants, specialists, secretary and clinic nurse, physiotherapist, psychologist, and twice a week, 3 hours each, with 3 staff members, consultants, specialists, and secretary. The secretary role is crucial in our unit. She starts with the patient. She's always receiving the patient, and she tried to modify the language, how the patient complains. This is very important in headache patients. She starts with demographic data. She took the context of the patient and start to system review. She's well trained for that, for doing that. The past history, and for headache analysis, we trained her to perform the analysis of the headache and to perform with the patient how he can explain his complaints. Then the patient will go through comprehensive assessment by the specialist. The need of Arabic language headache questionnaire is very crucial, and we started to develop culturally appropriate, validated, interviewer-administered structured headache questionnaire in Arabic language based on International Headache Society criteria. First, to allow a population-based epidemiological surveys in Egypt and also in Arab countries. We published this paper last year, and the validation of the questionnaire was excellent. The interclass correlation coefficient was 0.77. This is in Arabic. The primary headache questionnaire, the name, the age, sex, occupation, and other personal data. And then the screening questionnaire, the presence of headache in the last year, 1 year prevalence. Have you had a headache during the last year not related to flu, cold, or head injury? As recommended by earlier studies, but we put fasting instead of hangover to be fitted in our cartilage, in our culture. The second question is, how many headache types? Do you have just one headache or other headache types? Actually, we need more. We need more patient education. Which was trying to use headache diary with our patients, how to fill it. A specialized rule of assistant lecturer was history taking, clinical examination to exclude secondary causes and detect comorbidities and determine any allergies or contraindications to drug administration, a schedule for consultants every 1 or 2 or 3 months according to the availability of the number of consultants. And tertiary referral center, what about illiterates? Many illiterate patients came to our unit. We start to develop a diary for illiterate patients, and this is a number of months, and said to them, every day you will put dash if it's a non-headache day, and put 2x if it's moderate or mild headache, more than x, 5x if the headache severity is increasing. And we started to gain the feedback from the patients. Then for juniors, we started to do workshops for them to learn them the red flags, tips for history taking, rules of thumb. Many of our juniors are lacking the headache training in the undergraduate and even in the postgraduate teaching courses for them. We learned them to ask the right question in the right sequence based on the right suspiciousness, which will lead you to the right diagnosis, to listen to the patient quietly. Children more than 5 years are not bad historians. What the mind doesn't know, the eyes are not going to see. It means you have to have a sound knowledge. A more step forward is a community-based cross-sectional observation descriptive survey. Currently, we have about 500 patients following up with us in the clinic. We performed an epidemiological study that revealed that 1 year headache prevalence in Egypt was 50% of patients, while episodic migraine presents with 17.3%. Comprehensive management, we are stepping forward for performing the comprehensive management that include botulinum toxin in other than chronic migraine. We published a paper about botulinum toxin, could it be effective treatment option in intractable trigeminal neuralgia, and we also trying to learn our juniors that they have to perform a consent form, a written consent form, and a signature for each research they are doing, which is sometimes lacking in our research methodologies and logistics here in Egypt. We tried a neuromodulation trials, and we published a paper about repetitive transcranial magnetic stimulation versus botulinum toxin injection in CM prophylaxis. Still more to do. We have to do more cooperation with other related specialties pain specialties, psychiatrists, physiatrists, anesthesiologists, research work with other specialized clinics in neurology department, excellent to share in phase 3 trials, implement our experience and cooperate with other all over Egypt, and develop a multi-center patient registry and biorepository that will...
I think we have time for questions. Any question?
Beautiful, Hatima. Up to the point, thank you. You are operating in a university.
Yeah.
What's the limitations of establishing a headache clinic, and what is the limitations of establishing a headache clinic, and where do you think you're going with it? What is the future?
Okay, first limitation, I think I mentioned many of them, but in the university the limitation is time, trying to attract juniors for headache. This is very important for us. Also to establish guidelines for management, assessing the patient and treatment. I think we'll go to more cooperation if many centers are established in Egypt, not just one center or two. We have actually in Cairo, Qasr al-Aini and Ain Shams University, but we need more and more centers to be a multi-centric service for the patients. Thank you.
Only one question. One more. Here, Doctor.
Thank you very much, and I want to congratulate you because you mentioned that research is quite difficult, but I saw a lot of papers published in your center. So my question is about telemedicine. Do you deal with telemedicine with patients? Because I know Egypt, like other Arab countries, you have main centers, but you have a lot of patients in far and rural areas when there are no specialists. And so are you practicing some activities by telemedicine for headaches with patients?
Actually, we started this, but not in headache, in multiple sclerosis unit. It may be related to the character of the patient who use the technologies. It's 50% of our population have headache, but not all of them are seeking medical advice, and also not all of them are well trained for technology and for using the digital medicine. But I think the character of MS patients different from headache patients, yet it's not in the future, near future in our plans, but I hope it can be implemented. But right now it's not.
I suggest, for example, to use some simple things like using WhatsApp with patients, like also registering audio with some illiterate patients.
We did this actually in the private clinic, but not in the center. It's still not implemented in the center, but it's not yet implemented in our center.
Thanks, Professor
Thank you.
Hatim. Sorry,
You're
because,
right.
we are late and no time. We'll shift now to the second speaker.
Dr. Shireen Farag, Neurology, Ain Shams University. She will talk about rare primary headache.
Good morning. My talk today will be about rare primary headaches. Primary headaches are benign recurrent headaches not caused by underlying disease or structural problems. Fortunately, 90% of all headache patients are primary headaches. However, primary headache may cause significant daily pain and disability. The commonest primary headaches are migraine, tension headache, and trigeminal autonomic cephalgias. Other primary headache disorders occur less commonly and can be challenging to diagnose. The International Classification of Headache categorized the rare primary headaches into 4 categories: headache associated with physical exertion, headaches attributed to direct physical stimuli, epicranial headaches, and other miscellaneous headaches as hypnic headache and new daily persistent headache. The first is primary cough headache. It is a headache precipitated only by coughing or other valsalva maneuver. To diagnose it, it should be happening only with coughing, straining, or any other valsalva maneuver. It should be sudden onset lasting between 1 second and 2 hours. The primary cough headache is usually bilateral, posteriorly located, and predominantly affects patients older than 40 years of age. Associated symptoms such as vertigo, nausea, and sleep abnormalities have been reported by up to 2/3 of the patients. Primary cough headache is symptomatic in about 40% of lesions and mostly secondary to a posterior fossa lesion. The commonest is Arnold chilaryl malformation type 1. Other secondary causes include spontaneous intracranial hypotension, carotid or vertebral diseases, posterior fossa tumors, subdural hematomas, and reversible cerebral vasoconstriction syndrome. In pediatric patients, cough headache is considered symptomatic until proved otherwise. The pathophysiology of primary headache is not well understood, but it may be caused by increased intracranial pressure, which occurs secondly to increase the intrathoracic and intra-abdominal pressure. Treatment of primary cough headache, usually because of its short duration, there is usually no need to treat the acute attack. However, endomethacin 50 to 200 milligrams per day is usually effective. Other lines of treatment include topiramate, propranolol, and acetazolamide. Primary exercise headache is also known as benign exertional headache. It is precipitated by sustained physical exercise. To diagnose it, it happens only by a continuous sustained physical exercise. It lasts from 5 minutes to less than 2 days. The headache in primary physical exercise is usually bilateral, pulsating. It is more common in hot weather or high altitude. It's more common in patients with a history or a family history of migraine. It is very important to exclude the subarachnoid hemorrhage, arterial dissection, and reversible cerebral vasoconstriction syndrome. The pathophysiology is not well understood, however, it's mostly avascular in origin. Treatment of primary physical headache usually includes warming up before the exercise or having an exercise program that begins slowly and increases intensity and length over a period of months may prevent the primary exercise headache. Also, taking an analgesic as naproxen or endomethacin 30 to 6 minutes before the exercise may prevent the primary exercise headache. A primary headache associated with a sexual activity. When occurring at the first time, it is very important to exclude secondary causes. Explosive intensity just before or with the orgasm. It lasts from 1 minute to up to 24 hours. There are 2 types of primary sexual headache, either pre-orgasmic type or the orgasmic type, which in pre-orgasmic headache, it's dull aching, usually occipitally located. It appears during the sexual activity and increases with mounting the sexual activity. In the orgasmic headache, it is a sudden explosive headache, severe, throbbing in character, that occurs at just prior or at the moment of orgasm. With multiple explosive headaches during the sexual activities, reversible cerebral vasoconstriction syndrome should be considered. The pathophysiologic mechanism is not known, but the onset of the pre-orgasmic headache is associated with a tension type headache with muscle contraction in both the neck and jaw, while orgasmic headache is associated with sudden increase in the intracranial pressure. Treatment of primary sexual headache is usually reassurance, as the headaches are not usually recurrent. However, if they are recurrent, we can use propranolol, endomethacin, topiramate, and maybe a greater occipital nerve block. Primary thunderclap headache, it's a suddenly, extraordinarily severe and explosive onset headache. To diagnose it, it should be sudden in onset, reaching the intensity in less than 1 minute, and it doesn't last more than 5 minutes. Triggers for primary thunderclap headache are exertion, defecation, coughing, sexual activity, bathing, or emotional disturbance. Its mechanism is unknown, but it may be due to sudden change in the sympathetic tone of the blood vessels, which may cause vasodilatation, resulting in the headache pain. Although approximately 75% of the time of the thunderclap headaches are attributed to primary headaches, yet the remainder is attributed to various serious underlying. Primary thunderclap headache should be a diagnosis of last resort, reached only when all organic causes have been demonstrably excluded. Treatment of primary thunderclap headache is a self-limiting syndrome, and there is no treatment recommended other than simple analgesics. Cold stimulus headache, it is headache which is brought on by a cold stimulus, either applied externally to the head or ingested or inhaled. A headache attributed to external application of a cold stimulus, it resolves within 30 minutes after the removal of the cold stimulus. It is usually intense, short-lasting, stabbing headache, mid-frontally, and can be bilateral, temporal, frontal, or retroorbital. Headache attributed to the ingestion or inhalation of a cold stimulus. It's also known as ice cream headache or brain freeze headache. Usually the headache resolves within 10 minutes after the removal of the cold stimulus. The pathophysiology of cold stimulus headache is not completely understood. However, the cold temperature seems to be triggering the trigeminal nerve. Treatment is by warming the roof of the mouth, by drinking some warm water, pushing the tongue to the roof of the mouth, and covering the mouth and nose with hands. External pressure headache, it's the headache resulting from sustained compression or traction upon the epicranial soft tissues. External compression headache is maximum at the site of the external compression and resolves within 1 hour after the external compression is relieved. External traction headache, it is maximal at the site of the traction and resolves also within 1 hour after the traction is relieved. The mechanism responsible for is compression of the trigeminal or one of the occipital nerve branches. It can trigger a migraine attack in patients who are prone to such headache. Primary stabbing headache, also known as ice pick headache, it's transient and localized single or multiple stabs of pain in the head, extremely intense, that occurs spontaneously in the absence of organic disease of underlying structures or of the cranial nerves. To diagnose primary stabbing headache, each stab lasts for up to a few seconds. The stabs recur with irregular frequency from 1 to many per day. It's very important to know that it's not associated with cranial autonomic symptoms. That's how we differentiate it from the TAC syndromes. It involves the extra-trigeminal region in 70% of cases, and if it involves the trigeminal region, it's very common in V1 distribution. It may move from one area to another in either the same or the opposite hemicranium. It's commonly experienced by migraineurs and often can occur in the same location where they got their migraine headache. Treatment is often not required because of its short duration, but with frequent attacks we can use indomethacin, gabapentins, and melatonin. Nummular headache, it's a chronic pain in a small circumscribed area of the scalp in the absence of underlying structural lesion. To diagnose it, this area of the scalp should have the following characteristics: sharply contoured, fixed in size and shape, round or elliptical, from 1 to 6 centimeters in diameter. Any part of the scalp can be affected, but it's usually in the parietal region. The affected area commonly shows variable combinations of hypothesia, dysthesia, parathesia, allodynia. The quality of the pain is most commonly described as pressure-like, sharp, or stabbing. The pain intensity is typically mild to moderate. The pathogenesis of nummular headache is uncertain, but it may be due to neuralgia of a terminal branch of cutaneous nerves of the scalp. Treatment could be by simple analgesics. If not responding, we can give gabapentin, tricyclic antidepressants, or peripheral nerve blocks. Hypnic headache, also known as alarm clock headache. It's frequently recurring headache attacks developing during the sleep, causing awakening and lasting for up to 4 hours. It's important to know that it's not associated with cranial autonomic symptoms. It's more common in patients above 50 years, more in females, bilateral dull aching, mild to moderate in intensity. It's not related to sleep stage. A recent MRI study shows gray matter volume reduction in the hypothalamus. It's very important to differentiate the primary hypnic headache from cluster headache. In patients with primary hypnic headache, they are woken up by the headache at night. They read books, watch television, drink or eat, or walk inside the room. While in patients with cluster headache, they are excited and restless in states. Other causes which awaken the patients from sleep by headache: sleep apnea, nocturnal hypertension, hypoglycemia, and medication overuse headache. Treatment could be a caffeine drinking after awakening or maybe half an hour before going to sleep. Lithium, melatonin, and indomethacin can help too. New daily persistent headache. It's a persistent headache daily from its onset, which is clearly remembered. The pain lacks the characteristic features and may be migraine-like, tension type-like, or both. To diagnose it, the exact time is remembered by the patient. The pain is becoming continuous and unremitting within 24 hours and present for more than 3 months. It's typically occurring in an individual without a prior headache history. A characteristic and unique feature of new daily persistent headache is that most patients are able to pinpoint the exact date when the headache started, usually pairing it with a stressful condition. It's more in women than in men. Headache is bilateral, anywhere around the head. Pain is usually throbbing or pressing in quality, not associated with nausea, light sensitivity, sound sensitivity, or lightheadedness. The differential diagnosis includes chronic migraine, chronic tension type headache, and hemicrania continua. It has two subtypes: a self-limiting subtype, which typically resolves in several months without therapy, while a refractory subtype is resistant to aggressive treatment regimen. Primary new daily persistent headache is considered one of the more difficult headaches to treat. The treatment, due to common features between migraine and tension headache, we can use the treatment according to the symptoms involved. Thank you.
Thank you, Dr. Shreen. We can take one question. Two question. Thank you. Okay.
Thank you for your presentation. I have one question about what's the limit between pneumolar headache in some cases when it's more than 6 centimeters, 7 or sometimes 8, and usually on one side, and tension type headaches.
It's the criteria that is it's
Same
on one
criteria, but
side,
it's more than
localized.
6, 7 or 8
Use the mic,
centimeters.
Dr. Shreen.
Sorry?
It's more than 6 centimeters, but it's typically the same criteria than pneumolar headache.
Yes, but it's well circumscribed, elliptical or oval in shape. It's the shape of the area affected.
Yes.
Yes, while the tension is more diffused.
But there are some cases when it's more than pneumolar, but they don't belong to any of the classification, and
Okay.
you can call them tension type or unclassified in pneumolar, or
Don't know. Maybe it's a mix.
maybe associated.
Okay, thank you. I would like to thank Professor Dr. Osama Abdelghani, the organizer, Masr Alfin. It was my pleasure to share the Professor Dr. Mahmoud, and we are closing the session. Thank you.
Okay, we'll take 10 to 15 minutes of coffee break and then come back